built a NICU with individual family rooms. So this is actually a NICU. So we have 80, it's called a single family room NICU. So we have 80 of these, right? It is, I was talking about this last night, and please don't ask me because another 3 hours are going to go by. But we have 80 single family rooms, and parents can stay over, we work very intensively with the moms to get involved in kangaroo care and breastfeeding and helping them take care of the baby, learn how to manage the baby, do the changing and diapering and everything else. So here is the best situation because you're rooming in, but you're also in a NICU. And these are, this is sort of the new wave of new model of care in neonatal intensive care, and these are starting to be built more and more frequently. Acupuncture, right? There's this one study where they used acupuncture. They did acupuncture, daily, and they found that the duration of the morphine treatment was reduced in the acupuncture group, 28 days versus 39 days. That's a reasonable difference, a reasonable cost savings. And then again, these are non-pharmacological treatments where there's not data. I can't show you studies, but these are things that people use, they report, they say that they work. So different soothing techniques, positioning, swaddling, rocking. Again, that's sort of a no-brainer if you have a screaming baby. Minimizing environmental stimuli, massage, responding early to the infant's cues, which I'll say more about later. Demand feeding, or the whole idea of developmental care, of respecting the baby's sleep-wake cycles and not interrupting the baby because you need to do a procedure, and waiting until the baby wakes so that that's when you do your procedures. I mentioned kangaroo care, use of pacifiers, and maternal participation in maternal participation in the care of her infant, again, tends to do what I was just showing you that you can do easier in a neonatal intensive care unit.
Yes, I have a question for you. Do you have any studies on success rate of getting moms to stay? We have a 72-bed single-family room unit about to be 84 beds in Baton Rouge, and our problem is the picture that you show, it looks like the compliant mother who's there. Our issue is we're having trouble with having moms that are compliant with the program, so they arrive impaired to the point where they really can't stay and care for their child. So that's I think our bigger issue. I mean, we don't know how to troubleshoot having mom compliant and wanting to stay in order to get her to participate in that care.
Oh, so you're talking about visitation.
No, I'm just talking about, they can stay, it's not visitation, it's family time. It's moms are there and they're staying to get them to stay to care for their child and do all these bonding things and the feeding and the kangaroo care because we have the availability and they can stay with us. And we have a room that looks just like that, but A, we can't get them to stay, or B, most of them are not compliant and they're maybe on a methadone program, but they're poly drug addicts, so they're taking the pills and the methadone. So we have difficulty getting them to, I guess, to participate and be engaged and to actually help us to get the kids? So therefore, we want to go on to more pharmacological interventions because of that.
So they show up, but they don't get involved?
They don't always show up.
Okay.
If they do, oftentimes they're so impaired because they're not compliant with their program. So they're not only taking the methadone or the Suboxone, but they're also taking other illicit drugs or other prescribed drugs in addition to that.
Mm-hmm. Okay.
To be successful in all the things that you suggest, that's the crux of our problem.
Yeah, yeah, okay.
Do you all see that in your area?
We have to have a, I'm sorry, but we have to have a private conversation about that because it's a very complicated, in-depth issue and question, and I can tell you about it, but not in 2 minutes. I'm sorry, but let's promise to talk about it later, okay? So the other aspect of this, and we've been talking about it before, and again, this is something Paula may want to chime in on later, but you know, you can't treat the baby alone. If all you do is focus on the baby, you don't deal with the family and the mother-infant dyad, you are, I don't want to say wasting your time, but it's just not going to be effective. So mothers have their own psychological issues that need to be addressed, which typically involves or could involve some kind of psychiatric help, psychological help in the NICU, and also working on the mother-infant relationship, helping to foster the development of the mother-infant relationship, and that's also going to involve maternal involvement. The other thing that is useful, and I'm going to tell you a little bit about what we do that seems to be effective and is also done in other hospitals, is that we use neurobehavioral assessments in a variety of ways. It's part of standard care for all these babies. It's used for evaluation and management of the baby because we get a much better estimate of the baby's neurobehavioral actual status than you get with something like a Finnegan. And we use it with mothers to help them understand their baby's strengths and vulnerabilities, how to interpret the baby's signals and cues, which is why I said before, responding earlier to the baby's signals, because then you can prevent the baby from building up and getting so aroused and getting into an insulated crying state, getting to know the baby better. And what that also does is that it facilitates confidence in the mother's parenting abilities, facilitates a developing mother-infant relationship, or again, what someone called bonding. I hate the term bonding, just because bonding reminds me of glue, right? And a relationship that's glued, is not a good relationship. You need a healthy distance. And it also helps inform discharge planning, transition into the community. You can, obviously you want to convey issues to the primary pediatrician, the neonatal follow-up clinic if you have one, transition to home, and information for early intervention. So what I want to show you now, I want to show you two things. One is, this is a professionally made film, and it's about the specific neurobehavioral assessment that we use. And what you're going to see here is kind of stepping through and just vignettes on what this exam actually does in a healthy baby, okay? And I'm showing you this because then I'm going to show you a baby who's being examined who has NAS. And it's quite a contrast.
The overall goal of this procedure is to evaluate the neurobehavioral status of the newborn infant, in particular, infants who may be at risk for poor developmental outcome because of medical conditions such as prematurity, prenatal substance exposure, or stress. This is accomplished by first becoming certified in the administration and scoring of the exam by an established NAS trainer. The second step is to bring the infant, while asleep, into a quiet, dimly lit room, typically in the hospital or at home. Next, conduct the NAS examination as detailed in the manual and summarized below. The final step is to record the infant's scores for each item and compute overall summary scales. Ultimately, the NAS is used to provide a quantified neurobehavioral assessment that can be used to identify which infants are most at risk for poor developmental outcome, help with the care of the infant in the hospital, help the parents understand the strengths and vulnerabilities of the infant, make recommendations for treatment by healthcare and early intervention providers.
The main advantage of this technique over existing methods is that it provides an integrated, comprehensive, and quantified neurobehavioral assessment that has been proven to be successful in the identification of infants at risk for poor developmental outcome.
Generally, some individuals new to this method will struggle because of the training and certification process.
We first had the idea for this method when we were asked by the National Institutes of Health to develop a special exam sensitive to the characteristics of high-risk infants.
Visual demonstration of this method is critical to understand and correctly administer the items.
My colleague, Dr. Andriozzi, and I will be demonstrating the procedure with preterm babies in the neonatal intensive care unit.
Begin by observing the covered infant sleeping in sleep state 1 or 2. Record the infant's initial state as quiet or active sleep, drowsy, quiet awake, active awake, or crying. To test habituation, present the light to the infant. Repeat this with the rattle and a bell. Next, gently unwrap and undress the infant and place him supine. Record his posture as total extension, partial flexion, total flexion, or abnormal. Then, record the infant's skin color as normal, pallid, cyanotic, or mottled. Be sure to also observe skin texture and record any abnormalities seen, such as shedding or peeling, excoriations, loose skin, or deep creases around the eyes and nose. Now, observe the infant's baseline motor activity and record it as very little or none, normal, or excessive. Next, press the heel of the infant gently and record the number of trials it takes the infant to stop responding to the stimulus. Repeat this on the other heel. To start testing lower extremity reflexes, place the infant supine and hold one of his relaxed legs just below the knee. Then, press a thumb against the ball of the infant's foot to test plantar grasp. Record the response as no response, weak, normal, or exaggerated. Next, test the Babinski reflex by scratching the lateral side of the infant's foot. Again, record the response as no response, weak, normal, or exaggerated. To test ankle clonus, dorsiflex the ball of the infant's foot several times. Record the response as no clonus, 1, 2 or more, or sustained beats. Repeat the plantar grasp, Babinski reflex, and ankle clonus with the opposite leg. To test leg resistance and recoil, hold both of the infant's legs near the ankles with one hand with the index finger between the infant's feet. Next, fully extend the infant's hips and knees. Then, extend the thighs and legs and release. Record resistance to extension as none, little, moderate, or strong. Be sure to note the speed and amount of thigh and lower leg recall. Now, test the infant's power of active leg movements. Start by grasping the infant's moving foot above the ankle between index and middle fingers. Apply gentle resistance and record the active movements against gravity as none, minimal, moderate, or strong. To check popliteal angle, grasp the bottom of the infant's heel. Bring the infant's knee to his belly and extend the leg in one fluid motion. Repeat this with the infant's other leg. Then, record the angle formed at the knee by the upper and lower leg for the left and right legs. Next, test the infant's upper extremity reflexes. Using one hand, place the infant's arm above his chest. Place the other hand on the infant's trunk to prevent trunk rotation. Keep the thumb at the level of the infant's elbow. Now, gently push the infant's elbow across his chest so that his arm comes across his neck like a scarf. Repeat this with the infant's other arm, and then record the point on the chest to which the infant's elbow moves easily before encountering resistance. To test forearm resistance and recoil, start by holding both of the infant's arms at the wrist and fully flex his arms at the elbow. Then, extend his forearms and release one arm in 1 second, followed by the other arm 1 second later. Record the amount of forearm resistance and speed and amount of recoil. Now, test the power of the infant's active arm movements. Using the index and middle fingers, grasp the wrist of the infant's moving hand. Apply gentle resistance to the infant's movement. Record the movement against gravity as none, minimal, moderate, or strong. To check the rooting reflex, hold the infant's hands against his chest using one hand. With the other hand, stroke the skin at the corner of the infant's mouth. Record the response as none, turn away from, weak, full, or exaggerated head turn towards the stimulated side. Now, test the infant's ability to grasp a finger. Begin by placing an index finger or thumb in the palm of the infant's hand and press the palmar surface without touching the back of the infant's hand. Repeat with the infant's other hand and then record the response as none, weak, strong, or prolonged. To assess truncal tone, place one hand under the infant's buttocks. Using the other hand, hold the back of his head at the neck. Then, lift the infant a few inches above the crib so that his buttocks do not touch the surface. Gently flex the infant's trunk by bringing the head forward and then bringing the infant to a sitting position. Record the truncal tone as no tone, some tone, good tone, or exaggerated tone. Now, hold the infant's wrists or forearms. Extend the infant's arms and pull him to a seated position. As he is pulled to sit, observe if there is any muscular resistance to stretching the neck and if the infant attempts to move his head back into midline position parallel to his body. Hold the infant upright by placing both hands under the infant's arms around his chest, using the thumbs to support the infant's head. Now, lift the infant so the top of his foot is stroked and gently pressed downward against the edge of the crib. When finished, repeat with the other foot. Observe if the foot is lifted and then extends to place. To assess stepping, hold the infant upright with both hands under the infant's arms around his chest. Use thumbs to support the infant's head as before. Let the soles of the infant's feet touch the surface of the crib or table and move the infant forward as stepping occurs. Record the response as none, some, clear, or exaggerated stepping. If stepping was not elicited, note if the infant can support his weight, if his legs stiffen, or if they cross in a scissor-like motion. To assess ventral suspension, place a hand under the infant's chest and abdomen and suspend him in the air in a prone position over the crib. Record the final position of the infant's head, limbs, and trunk. Then, assess incurvation. While keeping the infant prone, with a hand supporting his chest and abdomen, slowly tap or stroke a line a few centimeters from the vertebrae, downward from the shoulders to the buttocks. Then, repeat on the other side. Record the truncal response as it flexes laterally in a concave curve on the stimulated side as none, weak, fully developed, or exaggerated. To check for crawling, make sure the infant is prone and then place his head in midline and arms near his head with his palms facing down. If he does not crawl spontaneously, stimulate the response by gently pressing palms on the soles of his feet. Record the response as none, weak, coordinated, or prolonged crawling, and whether or not stimulation was needed. From the crawling position, record the infant's head lifting as none, head turning, brief lift, sustained lift, or exaggerated response such as a hyperextended neck. Now, hold the infant in a cuddled position, taking care not to rock or talk to the infant. Facilitate cuddling only if there is no active participation from the infant. Then, hold the infant in a cuddled position on a shoulder. Record his ability to relax or mold, nestle, and cling, as well as if there is any resistance to cuddling. Rest the infant on your lap at a slight upward angle. Start by holding the red ball about 10 to 12 inches from the infant's eyes. Jiggle the ball to find the infant's focal range. Then, slowly move the ball horizontally from one side to the other. If the eyes and head follow to at least one side, move the ball vertically and in an arc to see if the infant continues to follow. Now, grab the red rattle and gently shake it 10 to 12 inches from the infant's eyes. Slowly move the rattle horizontally from one side to the other. If the eyes and head follow to at least one side, move the rattle vertically and in an arc to see if the infant will continue to follow. Take a position 12 to 18 inches in front of the infant's face. Slowly move from one side to the other. If the eyes and head follow to at least one side, move vertically and in an arc to see if the infant will continue to follow. While still positioned 12 to 18 inches in front of the infant's face, speak in a soft, slightly high-pitched voice and slowly move from one side to the other. If the eyes and head follow to at least one side, move vertically and in an arc to see if the infant will continue to follow. For the previous 4 exercises, record the infant's ability to become alert, focus on the object, follow with his eyes and head horizontally or vertically, and ability to coordinate head and eye movements. To record auditory responses, shake the rattle continuously 6 to 12 inches from the infant's ear and out of sight. Repeat this so there are 2 trials for each ear. Repeat this exercise by substituting a voice for the rattle. Move away from the infant's line of vision and speak softly into one of the infant's ears. Repeat so there are 2 trials for each ear. Record the infant's ability to become alert and to turn and/or look towards the stimulus. Now, hold the infant upright using both hands to support him under his arms, with thumbs across his chest and fingers around his back. Use fingers to support the base of his head. Rotate your trunk in a half circle. Then, rotate in the other direction. Observe the infant's eye and head movements, as well as the presence or absence of nystagmus. Begin by assessing the infant's defensive movements. With the infant's head in midline, hold a small cloth in place over the infant's eyes and nose, but be careful not to occlude the nostrils. Record the activity level of the infant, as well as the presence of non-directed or directed swipes of the infant's arms toward the cloth. Then, turn the infant's face slowly to one side and hold him briefly in that position with his jaw over his shoulder. Wait for the infant to settle and adjust his posture. Then, repeat this on the other side. Record the amount of extension of the infant's arm and leg on the side of his body his face is resting on. Finally, score each sign of stress abstinence as yes if it was present during the exam. Shown here are 5 profiles or types of infants based on their end scores from a sample of over 1,200 at-risk infants. Analysis is based on previously established summary scores measuring orientation, need for handling, self-regulation, arousal, excitability, lethargy, hypertonicity, hypotonicity, non-optimal reflexes, asymmetric reflexes, quality of movement, and stress abstinence. Note that infants with profile 5, depicted by the black line, show the most abnormal pattern. Seen here, infants with profile 5 were more likely to develop abnormalities between the ages of 2.5 to 4.5 with regard to the Bayley scales, the Child Behavior Checklist, school readiness as assessed by Dial R, and low IQ.
After watching this video, you should have a good understanding of the ENDS exam and its various applications.
Although this exam can provide insight into a broad spectrum of high-risk infants' neurobehavioral functioning, it can also be applied to direct care of the infant to inform developmental care practices in the neonatal intensive care unit.
The implications of this technique extend toward treatment of the infant at risk because it identifies specific neurobehavioral abnormalities that are amenable to intervention.
This method can help answer key questions in the child developmental field, such as what is the neurobehavioral repertoire of the normal newborn infant, and how can we identify neurobehavioral abnormalities? So the reason I wanted you to see this is because what you saw was a preterm infant close to discharge. So, you know, this is not a completely term, healthy Gerber baby, right? And, you know, so the baby did show some signs of stress and some other kinds of minor neurobehavioral problems, but you know, to show you a perfect baby would make the contrast kind of silly. So this baby, like I said, is a healthy baby at discharge, and what I'm going to show you now is a baby going through NAS with the same exam. It's not as good because we did it. It wasn't done by a pro, but.
So I'm looking at his posture and his skin color.